I'm about to drop knowledge, girl. I'm so glad. So here we go. All right, we're going to jump into this. Going to have to videotape these things. So we have a handful of videos that are available to you. Did Rick tell y'all about that? It's embedded somewhere on one of your things. I don't know which one it is. But unfortunately, the majority, a lot of our stuff, especially the things we really need, like IO and IV, somehow those videos got disappeared. I don't know where they went to. So I'm going to do some low-budget film action so we can upload this to YouTube so you guys can go back if you need a review. So what we're going to talk about real quick is albuterol. Last week, we discussed inhalers. We talked about how you guys now can administer. You no longer have to assist. We talked about 6 rights, and we talked about what the medicine is used for. So now we're going to go to that next thing, which is a nebulizer. It's something you guys will be able to carry as AMTs, and you'll be able to administer. It's very important, right? So now you can actually start to actively treat certain patients. Give me some examples of a patient that might need a nebulizer. An asthma patient, obviously. What did you say?
Patient that has like pneumonia and wheezing and needs local relief.
Okay, so wheezing obviously is one of the key indicators. That's an assessment that we would find. What types of disease path? What are we looking at? So asthma's one. Allergic reaction, right? COPD. So, COPD patients, absolutely. What else? What about CHF patients, right? What about just bronchitis, right? That could trigger some inflammation. So what is wheezing? It is constriction, is mucus buildup, right, in the lower airways usually, in the bronchioles. And so then when we administer albuterol, what are we effectively doing? We're dilating those bronchioles, right? So that helps with that gas exchange. Because ultimately, an asthma patient, they can breathe in just fine, right? It's the expiratory problem they have. So forcing that air back out, that's where you're going to hear those wheezes. Now, there are definitely a few things to know about asthmatics. So some are like what I would refer to as a brittle asthmatic. It doesn't take a lot to trigger an asthma attack. Those kind of folks can be very fragile. In fact, I'm going to encourage you to do this. So I hope your ears are turned on, your brain's engaged, and you're going to make a quick mental note on this. If you make an asthma patient, there are a few questions you need to get to quickly. Your sample OPQRST is going to be important, but I want you guys to throw in a couple extra ones. I want you to ask, how often do you have asthma attacks? I want you to ask, have you ever been hospitalized? And I want you to ask, have you ever been intubated? Patients that are hospitalized and patients that are intubated from an asthma attack can go from talking to you to dead before you even have a chance to get them on the way to the hospital. I saw it happen in front of my face. So I'm telling you, don't waste time. Don't waste time with treatment. Don't waste time with transport. You are going to treat on the scene. This is not a load and go situation necessarily immediately. Immediately you need to address the problem, which is going to be with oxygen, and then it's going to be with albuterol treatments. So you guys are going to be aggressive to that. But then you're not going to stay on the scene. Once you get the treatment started, we need to think about loading and getting out of there, because they can go from talking to you to bad. Now, there are those that are seasonal asthmatics. So sometimes when the seasons change, spring and fall in particular, their asthma kicks up. You have childhood asthmatics, so they will grow out of it as they get older. Some do. And then you also have exertional asthmatics. So somebody that starts to play sports. You may have someone who's playing a sport, and all of a sudden now they have an asthma attack come on. So now they got to take a step out. They usually have their inhaler with them, and they can correct the problem pretty quickly. Those things said, we're going to treat all the patients the same. Rapid assessment. Listen to breath sounds. And if they're having a really, really hard time talking, Adeline, should you ask them 9,000 questions right then? No. I'm going to give you a quick story. These are free. Josu, these are free. I'm not charging you for these, but I will throw them in so you remember stuff. I told you guys, or I may have mentioned to you guys, I had a Brazilian exchange student that stayed with me for almost a year, and she would come to class with me from time to time. This is how obvious it can be. We had an asthma patient. We were doing a scenario. The person just kept asking questions. And this girl's 16, and she's never done medical anything, and she doesn't speak a lot of English. And she grabs me by the arm. She goes, "It's okay. Why are they not giving oxygen?" I said, "I don't know." So if it's obvious to a 16-year-old that has never done anything medical, I should be honest to you guys. Oxygen treatment, albuterol. Let's talk about it. Comes in these cool little things right here. All right. So who can tell me the breakdown? What is the milligrams? What is the volume?
2.5 milligrams.
2.5 milligrams. Mixed in?
Saline, but I don't know how much.
Anybody?
0.3.
Okay, so it's 3 cc, 3 mLs. 3 cc's or 3 mLs, but cc's and mLs are interchangeable. It's actually sterile water. I used to say saline as well. I always thought it was. It's actually sterile water. I had to look that up. Somebody told that to me. I said, really? Looked it up. It is sterile water. That said, it's concentration and volume. Concentration being the 2.5 milligrams, and that's what's most important that you know. How much of this do you put into one of these things?
The whole thing.
The whole thing. The whole thing. Now, we have several up here. Thank you, Mr. Danny, by the way. We have several different versions, and there are even more than this. Nebulizers come in many shapes and forms, okay? This one here has this long, little bendy, flexy thing here. Nobody in here is old enough to remember what a popple was from McDonald's, which is sad to me. It means I'm old. But this is a spacer. This is to keep your medicine from wasting out too much. Obviously, they breathe in from this side. Remember, I think I said this last week. You don't instruct them to take a deep breath in and hold it. Tell them to breathe normally in through their mouth. In through their mouth. Okay? And they're just going to breathe until all of this is taken. It simply unscrews, put the medicine in the bottle. Like so. Now, what do you set your oxygen at? It's a range.
10 to 15?
I'm waiting to hear it. I'm gonna let y'all keep guessing that way we get it.
4 to 6?
Please do.
So your top number's correct.
2 to 6.
6 to 8?
Top number, 6 to 8. 6 to 8 is the range.
Top number.
6 to 8. Yep. Whatever, yo. We're videotaping, so just to let you know, you're coming on in. All right. That's you're good. 6 to 8. So what's your goal for this? You wait until you get a mist. That's the bottom line. So you turn up to 6, no mist. All right, we're gonna go to 8. This is not a very good mist. Say this one's broken, man.
Yeah.
Doesn't matter. Doesn't matter on this one. All right, so it should have a mist. If it doesn't have a mist, I don't know, find a different one. So we will hook up this dude. I'm going to show you all of these. Some of your services will have this. Memphis used to have these. I don't know if they still do, to be honest
The
with you.
mask one?
Yeah.
Yeah, we still got the mask.
You got the mask ones? Do you
Yes.
have these like this that go with the mask that have the little knob on the top? That's just to keep from wasting medicine, which I'm going to show them. A lot of the stuff usually comes disconnected in the bag, so you have to kind of put it together. All right. That's better. So these, if you have one of these little green button on top, the goal for this is that it doesn't waste the medicine. So the patient has to be strong enough to breathe in, and when they do, that knob will go down. I'm not going to put my mouth on this, Greg. Not, 'cause I don't know where this thing's been. But I would show you otherwise. So you breathe in, and the knob, the little ball on the top goes down, and then they breathe it in like that in medicine. That way they're not wasting. Now, let's say they're too weak and they really can't draw in that deep. You can override it by just twisting that, and now it's a continuous flow, so they can breathe in naturally. Again, they have to still be able to hold this for them to be able to use it. So let's just say they're too weak, they're too, the respirations are just, they can't do it, all right? So you need to help them out a little bit. That's why we have this mask. By the way, when should you turn this on, before or after you put the medicine in? After. I promise you, try to put the medicine in while this is turned on. You're saying I have a geyser in your eyeball, you've got albuterol in your eyes. It doesn't work the same as saline. I'm just letting you know. It's happened to me. You get excited, you're in the middle of a call, you turned it on, now you put the stuff in there on top of it. You're like, well, that did not work out like I needed it to. So all of these are just options, and you may have something different at your service. You'll have to know what your service carries. Really don't know. Turn it on. This will be a continuous flow, but now you can just put this on their face like a non-rebreather. Boom, it's on there. They're breathing it in. Easy peasy. When it runs out, check them, reassess the patient. That's the game plan here, is you reassess. after each treatment. They need more. Can you give them more? Of course. Is there any contraindications for this? Say that again.
Or never mind.
Oh, it's okay. I mean, I know this is the mask. I'm sorry.
He said not being able to breathe adequately.
Not being able to breathe adequately. So if they can't draw the air in themselves, they're having to be ventilated. Yes, you're right. That would not work out. So CPAP machines, and we're going to go over that. Actually, Rick's going to teach you that. Some, not all, some CPAP machines actually have a connector for this, so you can hook them up to albuterol treatment while they're on CPAP. That works really well. Not all of them have that attachment. So ultimately, the medicine itself is fine to give. Person asked me once before, what about the heart rate? Well, I had a conversation with the doctor, and they said the heart rate's elevated, but the justification is the fact that the patient still has too many wheezes, they're not breathing adequately, they need the medicine. That overrides the idea of a high heart rate, because they can treat a high heart rate, but if they don't get their lungs opened up, that's going to be the bigger problem. So that said, albuterol really does not have any, quote, contraindications if it's indicated for the patient's condition, provided the patient can breathe it in. So that's really the bottom line. That said, should you start an IV with patients like this that are on this? That are on this, should you start an IV? An INT? Yes, why?
Or push like, well, the medic can push volume over.
All right, so you're ahead of your game a little bit, but that's where I want you to start thinking. The idea is not so much everything you can do, it's what's going to be needed later. So think about that. So you guys may only be up to a certain level, but as soon as you pass care off, which if it's not to a paramedic, it's going to be to a nurse at the hospital or something, you guys need to have that in mind, that now they can give steroids. So an IV or an INT, as we're talking about, is going to be needed. So don't think, well, all I can do is give albuterol, I can't inject this in their veins. No, you can't, but there's other treatments down the road that patient may need, so the IV access is necessary. Yesterday, I didn't mention that, and there was some confusion on it. It's like, why should we start one on this? So I wanted to go ahead and mention that now. Any questions on albuterol? When you guys use this, yes?
I just had a situation question. So I worked with a medic one time, we were doing an albuterol treatment, and he kept a lot of nasal cannula. Is that something like classroom-wise we should do, or is that?
There's nothing wrong with that, unless you have two O2. So what does he have, like a portable and a main? Is that how he was hooked up to? I mean, it's not something you're ever going to see in a book. I'm glad you're mentioning that, because I need to I'm going to piggyback on that comment here in just a second. That said, is that wrong? It's not wrong. Is it taught? It's not taught either. And so I will talk about that. I just want to finish with this though. When you guys use this stuff in the scenarios in the lab, I want you to open it. I want you to get used to putting it in there. I want you to recap it. Right now we're out of oxygen on our small bottles. So if you're using a small bottle, you're not going to be able to turn on oxygen. I want you to get the muscle memory. Because a true story, when I came out of my paramedic class, we did very little hands-on stuff. It was mostly book taught. I know this was a long time ago, but still, the hands-on matters. And I found out later that one of my classmates, shortly after we got out in the field, had an asthma patient and did not know how to assemble one of these things and put the medicine in. I was like, you know what? I had to fumble with it myself. I figured it out, but I can see that. If you don't do something, it may be foreign to you. So I want you guys to practice like you play. Now, to piggyback on what you just said, you can stop on the skill, because otherwise it'll run too long and my battery will die, because I got to